The GI lecture has been broken down into 4 different parts to make it a little bit more manageable as you listen to the audio portion of the PowerPoint lecture. This first part of the GI lecture is actually going to look at assessment, diagnostic tests and labs, NG tubes, TPN, alkalasia, GERD, hiatal hernias, and some information on gastritis. So this very first slide is just a quick review of organs of the digestive system. So please, once again, review your pathophysiology to remember the functions of each of these different areas of the digestive system. When doing an assessment of the GI system with a patient, it's important to get a past history, things that can alert you to red flags that could lead to different disorders or problems that they're having. Could be changes in diet and appetite, smoking and alcohol can affect a patient's also their appetite. Noting if the patient has any particular abdominal pain, where it's at, what the pain is, what pain scale they rate that pain at, and what are the alleviating and aggravating factors. In other words, what makes that pain worse or what makes the pain get better. Also part of the assessment should include if the patient has any problems with indigestion or swallowing, nausea and vomiting, if the patient has had some major changes in weight, either that be gains or losses. Characteristics of bowel elimination, if the patient's had problems with constipation and diarrhea as a change. Family history of GI disorders, any history the patient's had of GI surgeries, and findings from rectal exam, either by assessment, objective assessment, or it could be by particular tests that the patient has had to examine the rectum and also the large and small intestine. Lastly, it's important to include what medications that patient could be on that could be affecting the GI system. Assessment of the GI also includes looking at the oral cavity, so that includes also condition of the teeth, if the dentures fit well, condition of the tongue and the gums. Remember, on certain types of oral cancers, those could be a non-painless type of a lesion, so it's important to look for those in the mouth. Also look for nodules and swelling and lymph node enlargement, especially in the anterior cervical chain, any discoloration, inflammation, or foul odor. Remember, foul odor to the breath could signify a medical condition. For example, an ammonia type of smell could indicate that the patient has some sort of liver dysfunction. A fruity, kind of sweet smell to the breath could indicate a diabetic problem with ketoacidosis, and a foul smell to the breath could also indicate infection or regurgitation issues, things like that. In inspection of the abdomen, it's important to note if the patient has any scars, if the abdomen is distended, flat, or concave, if it's symmetrical, and if the patient has bowel sounds present, and if so, if those are hypo or hyperactive or just normal findings. It's important, remember, once again, to inspect the abdomen before auscultating, and also that you always want to auscultate before you palpate the abdomen. If you would palpate first, then auscultate with your stethoscope, you could have created extra sounds by palpation that would have been not normal findings if you had just listened first. The other thing, when you do your palpation, remember it should be light palpation. Only experienced practitioners should do deep palpation in the abdomen because of risk to internal organs. And remember, always palpate areas of pain last. So when you're doing an assessment, if that patient is a suspected appendicitis, you would want to palpate the right lower quadrant as your last area of palpation. Picking up on masses and pain and tenderness is also part of your abdominal assessment. You'll be doing that with palpation techniques. The referred and rebound types of pain that are noted on the slide would be indicative of possible appendicitis issues. This is a really nice picture that depicts common sites for referred and GI pain. Remember, just like a cardiac patient can sometimes have referred pain into the neck, the jaw, and down the left arm, sometimes patients with internal abdominal disorder problems can have referred pain to other areas of the body. So as you look at this slide, you can notice that patients with pancreatitis may complain of shoulder pain, as well as patients with liver disorders may complain of right shoulder discomfort. So that would be because it's a referred type of pain to that area of the body. Bowel sounds, typically, bowel sounds should be between 5 and 34 bowel sounds per minute. That's a normal finding. Hypoactive is less than 1 per minute. In the patient that has hyperactive bowel sounds, you'll hear more than 34 per minute, and it'll be like a gurgly kind of a sound. If you've ever had gastroenteritis symptoms, you've probably noticed how your stomach was in hyperactive mode and your bowel sounds were very hyperactive. Patients also might have hyperactive bowel sounds if they have pyloric obstruction or diarrhea due to any number of causes. The patient with absent bowel sounds, you need to actually listen for a full 5 minutes to be able to determine that that patient has absent bowel sounds. And causes of absent bowel sounds could be peritonitis and ileus or obstruction. Another part of the assessment is to look at GI secretions, GI excretions. So in other words, what that patient's stool looks like, and that can really indicate a lot of different kind of disorders. It gives a lot of information. Those patients that have had upper GI bleeding or high iron content will have dark tarry stools. Patients with GI bleeding, you're going to know it. They'll have a large amount of dark tarry stooling, and it will be very, very foul smelling because of the blood. Stools of patients with lower GI bleeding will have a bright red appearance. If they have a biliary obstruction, it'll be typically clay colored. And if they have emesis from retained blood in the stomach, it'll look like coffee ground emesis. Emesis that has the presence of bile will be a green shade, and stools of patients who have recently had barium contrast or who have biliary obstruction will have white or gray types of excretions, and stools that have an increased fat content will be bulky, greasy, foam-colored, kind of grayish, and fat in the stool is known as steatorrhea, and a common patient disorder that has this type of stool would be the patients that have cystic fibrosis. Diagnostic tests to look at the upper GI tract would include different types of like a barium swallow, things like that. Typically those are going to be used to look at the esophagus, stomach, duodenum, and upper jejunum, and those patients need to be NPO for 6 hours before the test, and they'll have a laxative afterwards to help to get rid of that barium. These can help to diagnose an upper GI, can look at esophageal varices, can help to diagnose hiatal hernias, foreign bodies, polyps, tumors of the esophagus, or also tumors of the stomach or duodenal bulb. So they're very helpful to look at all those different kinds of disorders. This is just showing you an X-ray of an upper GI series and what that would look like if you had to visualize that being done on a patient. Other diagnostic tests would be a barium enema. This looks at large intestinal disorders. It looks at structural abnormalities of the rectum and the colon. These patients are also given a contrast medium, and it can detect colon polyps, tumors, and chronic inflammatory bowel disease, as well as obstructions and narrowing or dilations of the colon. So if both an upper GI series and a barium enema are needed, the barium enema is going to be done first to prevent barium from the upper GI series from entering the colon. So if that patient is being evaluated for possible colon cancer, the patient needs to be placed on a low residue diet for about 1 to 2 days before the barium enema. So typically other interventions are to restrict dairy products and follow up with a liquid diet 24 hours before the test, and keep the patient NPO for about 8 hours prior to the test. Laparoscopy we've talked about in previous lectures. Patients will be NPO before this. There's usually not any prep before it. They will have a puncture incision site at the belly button, and then Band-Aids or steri-strips over this incisional site. And carbon dioxide is used to inflate the abdomen for better visualization. So Due to that CO2 being infused into the abdominal cavity, that patient may have increased cramping, gas, and chest or shoulder pains after this particular type of test. This is just once again a depiction of a picture of what a laparoscope would look like. Another diagnostic test is called an EGD. It's the esophagogastroduodenoscopy, and this actually looks at the esophagus, the stomach, and the duodenal mucosa, and it can look for upper GI bleeds, gastric malignancies, and different types of ulcers. It's usually done with a flexible endoscope, and if the patient also needs a barium swallow done or an upper GI series, this is usually scheduled after 2 days or more after they've had that barium swallow or upper GI series. So it can also pick up on if there's any esophageal strictures, varices, tumors, alkalasia, which we're going to talk about in a later slide, and also hiatal hernia. And it can actually remove gastric polyps if that's the patient's problem. Nursing interventions are listed there on the slide. So make sure that that patient knows they will receive conscious sedation. And of course, it's important for the nurse then to check frequent vital signs and a gag reflex after the procedure. The patient will have a sore throat from the procedure, so throat lozenges and saline gargles kind of help with that. And watch very closely that patient for any aspiration or perforation problems. This is an example of what an EGD would look like. And the patient is typically positioned on the left side because that gives better visualization of those structures as it goes through the esophagus, the stomach, and then down to the duodenum. A gastroscopy would simply be where they're just scoping to look only into the stomach area, and could look for different types of abnormalities that are going. And as you can see, the physician would be looking at the endoscope video monitor to be able to see exactly what's going on inside the patient as they scope them. An endoscopic retrograde cholepancreatography, or an ERCP, will actually examine the pancreatic and biliary ducts. This can be used to release gallstones. It's done by a fiber optic endoscope with fluoroscopy, and this actually gets advanced into the common bile duct and the pancreatic ducts, and then a contrast medium gets injected to be able to visualize these structures. So the care is very similar for the patient that had an EGD done, and be very careful and watch that patient for signs and symptoms of pancreatitis after this particular test. Here's a diagram of what that type of scan would actually look like. Another commonly used diagnostic test is a sigmoidoscopy. This can actually visualize the anus, rectum, and distal sigmoid colon. It's used for polyp and tumor removal. The patient will have a Fleets or cleansing enema before, and it's important to watch for distension, tenderness, or bleeding afterwards. Remember, if the patient did have polyps removed, it's important that the patient's told not to have heavy lifting for 7 days and to avoid high fiber foods for about 1 or 2 days after this particular test. Here's a diagram of a sigmoidoscopy on a patient. A colonoscopy looks at the entire colon. It's a good diagnostic tool for possible colorectal cancer. Bowel prep solutions include Go Lightly or Colite, different types of solutions. Depending on the protocol for preparation, the patient may receive a clear liquid diet, strong laxatives, and enemas, and the patient will typically be NPO for about 8 hours before the test. They'll be sedated with conscious sedation before the procedure, and the nurse then would be responsible for monitoring vital signs and making sure that they made a full recovery from this. This can actually be used to evaluate both benign and malignant growths. It can remove polyps, take biopsies for specimens, and it can help to localize areas of bleeding that the patient may have within the colon. So it's generally considered the gold standard for diagnosing colorectal cancers. And here's an example of what all can be visualized through a colonoscopy. Ultrasound may be also used to look at organ shape, size, and position of abdominal organs. Can also pick up on cysts, tumors, and stones. And typical nursing interventions are to keep the patient NPO for 8 to 12 hours, and then after the test, they're allowed to resume normal activities and diets. A CT scan will be another tool used to assess abdominal organs. The CT can be with or without contrast. If it's with contrast, then they're going to need an IV access, or they could be given an oral contrast medium depending on how the test is ordered. So remember, if they're getting IV contrast, it's important to look for any allergies to contrast mediums. So check concurrent allergies to iodine, seafoods, those types of things. The patient will be NPO for about 8 to 12 hours. And if that patient is having barium studies done, those should be done at least 4 days before the scan is done, or after the scan, so that it doesn't interfere with the results from the scan. An MRI is probably gives a little bit better images than a CT scan, but unfortunately is more expensive. So that's why sometimes you may see a CT ordered first, and then if they didn't get good visualization, an MRI may be ordered next. An MRI costs about 1/3 more than a CT scan does. The images with this are actually a higher quality, and the MRI doesn't use ionizing radiation, so there's not that exposure to X-rays as in with a CT scan. And the contrast medium that's used can be injected intravenously also. Because, however, an MRI does have that magnetic field involved, it's really important that that patient removes any jewelry or metal, and also any patients that have implantable metal parts, such as pacemakers, heart valves, internal medical clips, implanted pumps, internal fixation devices, perhaps from injuries to the spine or to the long bones. Those patients would be, depending on what type of fixation devices were used, it could possibly be contraindicated for that patient to be able to have an MRI scan. If a patient has a cardiac stent in, that is usually okay once cleared with the cardiologist. One issue is that these scanners can be very claustrophobic. So patients that suffer from claustrophobia may actually need an anti-anxiety agent given to them before they have this particular test done. Stool for occult blood is a very simple test. You've probably all done one of these before. It can help to identify bleeding in the GI tract. Hemoccult is one of the common ones that we use in the hospital setting. And as you remember with this, you actually just put the stool on the slide, add the reagent, and if the color turns to a blue color, that's considered a positive finding, and it does indicate occult blood. Usually, because there's that risk for false negatives, this test is usually done 3 times to confirm a positive. And false positives could be if the patient had ingested a lot of meat, poultry, or fish within 3 days, or if the patient is taking aspirin and NSAIDs, or if the patient has had high doses of vitamin C and those types of things. NG tubes are another type of tool that's used for patients that have abdominal disorders. They can be used for decompression, drainage, or feeding purposes, as you all know. Nursing interventions are to insert them, make sure they're in the proper position, make sure that they're taped so that they stay in the proper position, confirming the placement through either an air bolus or another method. They can be irrigated as ordered and as needed. Make sure that that's taken in as part of the intake and output, and make sure that patient gets oral and nasal hygiene when having a tube in. So remember, they can lead to fluid and electrolyte imbalances, aspiration issues, and it can also irritate the GI lining. So make sure patients are watched for those kinds of things. And when the tube gets discontinued, just make sure you are removing it correctly and discarding it per hospital protocol. Some fluid imbalances that can occur if the patient is getting some sort of a hyperosmolar tube feeding, if it's not diluted properly, could be a cellular dehydration problem, because the fluid actually gets pulled from the intracellular fluid to extracellular. So make sure your patient is getting enough free water to prevent this type of a problem, and just follow hospital protocol on giving NG feedings. Feedings can be given in different methods, as you all know, either by intermittent bolus, by gravity or with a pump, or by continuous method with a pump, or they could be given cyclic, where the patient may get actually an 8 to 10 hour chunk of time where they're getting the NG feeding, and that's typically given a lot of times during the night while the patient's sleeping. So remember, we can give these feedings either through the NG route, a G tube route, or a J tube route. And some nursing responsibilities for patients receiving these. One is to check the gastric residual, which is the amount of tube feeding that's left in the stomach. So typically the residual will be checked on intermittent feedings about every 4 to 6 hours. Before the intermittent feeding. And if the patient is having a continuous tube feeding given, then every 4 to 6 hours the residual should be checked. The rule of thumb is on intermittent bolus feedings, if the residual is more than 100 to 150 mLs, usually the physician is contacted to see if they want the feeding held and have the amount decreased for future feedings. And of course, that's going to depend on how much the patient actually takes in. Obviously, if it's a ped patient, that residual may be quite a bit less than that, especially if it's a baby that's getting NG or G tube feedings, and they may not even be getting a total of 150. With a continuous feeding, usually if that residual is 2 times the amount over what they got per hour, then usually that's going to be held and physician notified. So if that patient needs feedings held, make sure you find out how the orders need to be changed for in the future, either to decrease the amount that the patient gets per feeding, or how many milliliters per hour if it's a continuous, or how many hour lapse in between feedings, those types of things. Remember, when you check that aspirate, that's always returned back to the patient via the NG or G tube, because it has a lot of electrolytes and nutrients in it. So you don't want to ever aspirate that fluid and then throw it away. It goes back into the patient. If the patient's not a good candidate for NG feedings or bolus feedings through a G tube, then the patient may be receiving TPN solution. Any patients that go without food or fluid for a few days need to be on some sort of nutrition, and TPN is the common nutrition used, TPN and lipids. Typically, TPN needs to be given through some sort of a large central vein. Subclavian and jugular veins are commonly used. And the issues with TPN is there's always that risk for a glucose imbalance, because TPN is very, very high in glucose. Most solutions are a 25 to 50% solution. And what happens is that the pancreas starts to secrete more insulin to cover this high glucose load that's in the blood. So the patient actually needs to be on blood sugar checks about every 6 hours. And many physicians will order regular insulin to be added directly to the TPN solution. Remember also to follow hospital protocol as far as hanging new TPN bags. Typically 2 RNs need to check the TPN solution against the medication administration record before a new bag is hung. And the tubing is typically changed depending on your hospital protocol, but a lot of times every 24 hours versus every 96 hours for just regular tubings. And the dressing over the central vein site is typically changed every week, or whatever your hospital policy states. Some nursing interventions to prevent glucose imbalance would be to make sure that that patient has orders for fasting blood sugar coverage with regular insulin on a sliding scale, to look to see if that patient has regular insulin added to the TPN if it's ordered that way, and typically to do what we call windowing the TPN, where the dose is actually decreased, usually like an hour before and an hour after the TPN is started, so that you can kind of get that pancreas in sync with all this glucose coming on board. And TPN, of course, is always going to be run on an IV pump to monitor it closely. A couple disorders we're going to look at in this first lecture. One is called alkalasia, which is a motility disorder where the lower esophagus muscles and sphincters don't relax appropriately in response to swallowing. So that patient has a lot of trouble being able to swallow their food down. They have symptoms of heartburn, chest pain. They usually lose quite a bit of weight. And management usually includes putting the patient on medications such as nitrates and calcium channel blockers, also perhaps Botox injections, and they may need actually a pneumatic balloon dilation to help open up that sphincter area and where the blockage is. So this is a great picture that shows a diagram of what alkalasia would look like. And so it shows you there where the muscle contracts as the food tries to come down the esophagus, and that's why the patient has such trouble swallowing and why they have impaired nutrition and weight loss. Another common disorder that we see in the population is GERD, gastroesophageal reflux disease. Probably affects about 20% of all adults. And it's caused because of reflux due to inappropriate relaxation of the lower esophageal sphincter. So symptoms these patients have are heartburn, regurgitation, belching, a lot of gas. They may have a nocturnal cough, and they may even have wheezing and hoarseness as a result of their GERD. So typically it's going to be diagnosed with a barium swallow and upper endoscopy, and treated with antacids, H2 receptor antagonists, proton pump inhibitors, anti-ulcer meds, and promotility agents such as Reglan. So remember that H2 blockers will decrease gastric acid secretion. They block the ability of the histamine to stimulate the acid secretion by the gastric parietal cells. So a couple examples of those kinds of meds would be Tagamet, Pepcid, Zantac, and Axid. The proton pump inhibitors work slightly different. With these particular meds, they inhibit the hydrogen potassium AT pump, so gastric acid secretion is decreased. And typically these patients may take these 2 times a day at first, and then after 8 weeks or so can cut down to maybe just 1 dose before bedtime. It's important with PPI meds to monitor liver function tests, and some examples of those might be Nexium, Prevacid, Prilosec, and Protonix. Those are some examples. If medications do not work for that patient, the patient may require what's called a fundoplication, and there's a figure that you can see of that in your book. This is just showing the reflux bolus that's seen with the GERD patient. Hiatal hernias are when the distal esophagus and a portion of the stomach move actually up into the thoracic cavity through an opening in the diaphragm. And with these patients, there's impaired blood flow, and there's a risk that the tissue can actually become necrotic if it would herniate up there and actually not get a good blood supply. There are 2 different types. There's a sliding hiatal hernia, where the upper stomach and junction displace upward above the diaphragm. That's what most hiatal hernias are, about 90%. And then there's also a rolling hiatal hernia, where all or part of the stomach pushes up through the diaphragm. This slide depicts the differences. If you see the sliding hiatal hernia in the middle picture, and then the rolling hiatal hernia would be depicted on the picture to the right. These patients may be asymptomatic, or they may have the same types of symptoms as GERD patients did, and typically they're treated with antacids, H2 blockers, PPIs, and also they might be patients that are good candidates for fundoplication, as we talked about with our GERD patient. So here's an example of what a Nissen fundoplication would look like. If you look at the picture to the right, it shows what actually happens as the gastric fundus is wrapped around the esophagus, and it kind of helps to reinforce then that lower esophageal sphincter, and it anchors it below the diaphragm. The last part of this first portion of the lecture is going to look at acute gastritis, which is an inflammation of the stomach lining. Could be caused from aspirins, NSAIDs, alcohol abuse, and radiation. Could be things that the patient takes in their diet also. And symptoms are anorexia, nausea, vomiting, abdominal cramping, diarrhea, epigastric pain, fever, and the patient may also have GI bleeding. So management includes not only removing the cause, but also giving antacids, H2 antagonists, PPIs, and perhaps even making that patient NPO until that area of the stomach can heal. There's actually an inflammation of the stomach lining from the ingredients of what's in the gastric contents. That's what causes that breakdown of tissue. For patients with chronic gastritis, one of the most common causes is called H. pylori, which is actually a type of bacterium that can eat away at the stomach, so to say, and that's typically treated with antibiotics and proton pump inhibitors and H2 blockers. So chronic gastritis can lead to atrophy of the gastric tissues, which will interfere with digestion and gastric emptying. So those patients may have dyspepsia or may be asymptomatic, and management includes diet, resting the stomach, decreasing stress, and then treating that H. pylori with antibiotics, as we talked about. And this concludes the first portion of the GI lecture. Peptic ulcer disease is actually an ulceration through the protective mucous membrane into the inner wall of the stomach. The causative factor for peptic ulcer disease is actually H. pylori. And I think we'll stop this here so that we can start it back up so you can take a break and get it in another audio portion so that you don't have to sit for so long.